All right, everyone. So we'll go ahead and get started. Um, so luckily, I get to do this lecture twice because I recorded it yesterday and it did not save. But in that process, I realized this is a lot of information, so it's going to be two videos instead of just one really long one. But this is high yield stuff. So the pathophysiology is important to understand because it's like foundational knowledge to where if I had a better understanding of this in EMT and paramedic school, I feel like I would have been a lot better paramedic to understand. So again, this can be very overwhelming, but I want to reiterate something that when we talk about certain disorders in this chapter, realize that we're going to hit this over and over again in subsequent chapters. So again, this is just kind of foundational knowledge, general pathophysiology, general pathology stuff. So don't try not to get too overwhelmed by this. Okay, now the what is pathophysiology? So patho, right? Pathology, so disease or injury, right? And physiology is how cells interact within the body, right? So we're looking at how does disease make the body work in a different way, and that's pathophysiology. And specifically, it's more commonly refers to like at the cellular level, but it doesn't have to, right? So basically, what does disease look like in motion, right? Like, what does the body look like when it's diseased? How do cells work or not work? And that's what pathophysiology is studying, okay? Now, the book wants you to know about something called, well, it's not what it's called, but it's adaptation to injury and stress, okay? So when cells are exposed to stress, whether it's radiation or heat or fatigue or exercise or whatever the stressing factor might be, they can adapt. And sometimes they adapt well, and sometimes they don't. So we're going to talk about these cellular adaptations due to adverse conditions, right? Whatever that adverse condition or stressor is, okay? So the word atrophy is when you have the same number of cells, but they decrease in size. So a classic example of atrophy is someone who's had like a right-sided stroke, and they can't use any muscles on the right side of their body. So what you'll see is their right arm and bicep is going to shrink in size. And what's happening in that scenario is atrophy, and they're still going to have the same number of muscle cells in that bicep, just those cells get smaller. So atrophy equals same number of cells, just smaller in size. It's traditionally from decreased usage. Okay, that's the traditional example. Atrophy is most commonly related to like skeletal muscle. Like I would say that's probably where you're going to see this example used most often. As opposed to the complete opposite, hypertrophy, excessive, right? Trophy is like the building up of muscle, or not muscle, building up of, right? So basically, hypertrophy is the same number of cells, they're just going to get bigger. So the same example or similar example could be I could go to the gym and just do a bunch of bicep curls, and then my arm is going to get bigger because it's adapting to this adverse effect and stress that I'm putting on by lifting up that dumbbell. So what happens is I still have the same number of skeletal muscle cells in my bicep. It's just those cells adapt and they get bigger. And that's cellular adaptation. So again, hypertrophy equals same number of cells, they just get bigger in size. That's hypertrophy. And then moving forward, hyperplasia. Hyperplasia is when there's more cells. So the classic example of hyperplasia is benign prostatic hyperplasia, BPH. Your grandpa might have this. What happens is the prostate will grow in size and it'll increase the number of cells, glandular cells within the prostate, based on testosterone exposure. So as men get older, they've had a lifetime exposure of testosterone. So the cells within the prostate will increase in number, okay? And that's hyperplasia, okay? So hyperplasia equals more cells. Not necessarily bigger cells or smaller cells. It really refers to there's just more of the cells. And we see this classically in benign prostatic hyperplasia, okay? Dysplasia, this is when you'll have a change in cell structure. So this is really getting really close to cancerous. It's not quite cancerous because it can be reversible. But I'm going to come back to dysplasia because I want to talk about metaplasia, which will kind of tie into dysplasia. So metaplasia is the change in cell type. And the classic example of metaplasia is something called Barrett's esophagus. So basically, your esophagus isn't designed for a bunch of acid to be on it all the time. So if someone has GERD, like gastroesophageal reflux disease, right, where they're just burping up acid all day long and burning their esophagus, the esophagus, due to this adverse reaction and adverse conditions, the stress that's been placed upon, will decide to itself, well, if I change these cells to stomach cells or intestinal cells that can handle acid, this won't hurt as bad. So the cells will change cell type from more like a skin type cell to an intestinal cell, and that's called Barrett's esophagus. And it's a reaction to the acid that's hitting the esophagus. And so that's metaplasia. And this is reversible, right? So if someone were to quit having burping up acid, this would go away. It would revert back to the normal cells that are supposed to be there. But if it continues, it can convert into dysplasia. And dysplasia gets really, really close to being cancerous. So the thing I want to point out on this slide is this metaplasia and dysplasia are reversible. Okay, as in, if whatever's the adverse condition stops, the cells will revert back to what they're supposed to be. But if they're not, you risk a high chance of neoplasia, which is a medical word for cancer, right? New plasia cells, right? So new cells, right? So neoplasia is the fancy word for cancer. You've probably heard of a neoplasm, okay, which is a tumor. So just be aware of this. This could actually be tested occasionally. They could ask, what is atrophy? Or, someone's had a stroke and their muscles have decreased in size. What is that? It's not dysplasia. It's not metaplasia. It's atrophy. Okay. So that's kind of how this will be tested occasionally. Now, it talks about fluid balance. So basically, the body works really hard to keep our fluid balance, and it does it in a variety of ways through the kidneys mainly. But just be aware, this fluid balance can also affect electrolytes. So, if you have sweet tea and you add a bunch of water to it, you're going to have less sugar concentration in there. Well, the same said for our body. If you were to dump a bunch of water into the body, you could dilute the blood. And so that could cause electrolyte abnormalities. And the same could be said. If you pee off too much water, you could have a high concentration of electrolytes. So this electrolyte balance becomes really important clinically because as a general rule, which I'm about to show you on some future slides, anytime you have an electrolyte imbalance, you have to worry about the muscles, the brain, and especially the heart not working properly because they're really dependent on these charges. And I'll talk about that. But it doesn't surprise me that, the degree of fluid imbalance required depends on the patient's size, age, and their underlying medical condition. Have they been having nausea and vomiting and diarrhea for 5 days and they've pooped out 6 liters of fluid or, lost 6 liters of fluid in the process? Of course, they're going to have a different fluid need than, someone that has a bloody nose, So it just kind of depends on the underlying pathology, and that's pretty intuitive and obvious. But this is something that we see a lot. And we actually get called for this a lot. This is edema, obviously. So edema is the medical word for swelling. I'll say that again. Edema is the medical word for swelling. So edema just doesn't have to be in the feet. You can have something called pulmonary edema, cerebral edema, orolingual angioedema, right? So swelling of the mouth or the tongue. You can have edema anywhere, right? But edema is excess fluid trapped within the body tissues. It could be in the cells or outside of the cells in the third space. So it's a very broad term. Edema literally just means swelling. But what they're pointing out in this picture is someone's very, very swollen feet. And if you were to go look at grandma or grandpa's feet, they might actually look like this. Because what happens is fluid will get stuck down here for a variety of reasons. Probably the most common reason is their heart is failing, so heart failure. It takes hydrostatic pressure, like it takes pressure to pump blood up out of the feet and back up to the heart. And when the pump doesn't work very well, it can't pump it up. So what happens is it'll end up leaking, for lack of a better word. It'll leak out into the third space. What's the third space? The third space is the space between cells. So it's not in the veins or arteries, it's not in the capillaries, and it's not inside the cell. So we call that the third space. So when that happens, swelling will occur. This can also happen from like renal failure and too much salt intake and a lot of other reasons. But what I'm trying to get at with this is edema is really common. And this is a severe case of edema. And how we assess this is you take your thumb and you push down, like right here, really, like on their tibia. it's called tibial edema or pretibial edema. And so what you do is you'll push down on that with your thumb and you'll hold it for like 3 seconds. You don't have to push like crazy hard, but you're trying to indent the skin, and then you'll let go. And normally, like on someone like me and you, our skin will go right back because there's not fluid stuck there in the third space. But on someone that has heart failure or renal disease or both or whatever, it will stay indented. So what I'm getting at is this word called pitting edema. Pitting, whoops, pitting edema. That's when you push down on there and it stays pitted, like a pit. And what's happening is there's just straight up fluid in that space and no protein. So it kind of like displaces them temporarily and it comes back. So again, you push down on grandma's leg and then you let go and it stays like a divot for 10 seconds. That's severe. That's severe pitting edema. And that happens actually. So you'll see this clinically. I bet if you on your first ambulance rotation, if you push down on a patient's tibia like that, you'll see pitting edema on someone. This is very, very common. Okay, so just something to be aware at. And you say, well, Hunter, why do I need to know the difference between pitting edema and just straight up edema? Well, we don't really see a lot of a just straight up edema where it doesn't pit. The time that this happens most commonly is something called lymphedema. Lymph has protein in it. So what happens is like someone will have like big elephant legs and you can push down on it and it's like springy, like boing, boing, boing. It doesn't stay indented. And we see that most commonly in a condition called lymphedema. We don't see that a lot, but where I'm getting at is when you see pitting edema, you should be like throwing off fireworks in your head and be like, they probably have heart failure and or renal disease. So you should start looking into that. Okay. Now, the word isotonic fluid. Okay, so you don't really need to know a bunch about this, but we give patients normal saline, right? And that percentage of stuff in there is 0.9%. And the idea isotonic, as in tonicity, right? The amount of electrolytes in a solution, iso means like the same. So when we give an isotonic crystalloid or an isotonic fluid, we're giving fluid that's supposed to match the blood tonicity. That's the idea behind that. So if someone very intuitively has an isotonic fluid deficit, we have a decrease in extracellular fluid with proportionate losses of sodium and water, right? So basically someone has just lost volume, but they've lost like the right amount of salt and water. So that's what makes it isotonic. If someone loses too much too much water and not enough salt, then it can change the tonicity, which is a whole nother discussion. And then isotonic fluid excess, paramedics are guilty of this. Sometimes we'll dump too much fluid into someone, like we'll start an IV and we forget to turn it off, or we turn it up really fast and we forget that it's running as fast as it is, and you start charting and you look up and you're like, oh my gosh, I just gave too much fluid. So you can give fluid excess through an IV pretty quickly and easily, but usually it's not too harmful. So, but you don't want to do that, of course. But anyways, that's pretty intuitive. Now, we're going to run through these pretty quick. Let me be very clear. You do not need to memorize these values, okay? But I want to point out some words on here because they're a little bit tricky, but they're intuitive if you know the periodic table of elements, right? So electrolyte imbalances, right? So sodium, before we jump into this, let me point something out. We're going to talk about electrolytes. And the reason that electrolytes, and we test this clinically, like in the hospital, in the ER, become important is because if we have too much salt or too much potassium or not enough potassium and too much chloride or whatever, not enough magnesium, we end up with imbalances in charges, okay, between cells. And so you have to realize that muscle contractions, nerve impulses, endocrine stuff, it's all almost every cellular, I would say the majority of cellular function is dependent on charges. And so when you have too much positive charge and not enough negative or whatever, these charges get jacked up. And so that can manifest its way in several ways. The most common ones we'll see in the pre-hospital environment is like neurological deficits, like altered mental status. Okay, so the brain's very dependent on sodium and glucose and potassium and calcium and all these different charges to take place for neurons to fire. And when that gets jacked up, you see psychosis or altered mental status or something to that effect. And then the other thing that you'll see is, so neurodeficits, one. The second one you'll see is like muscular issues, right? So people will have cramps, or they're, not going to be able to walk very well. They'll have fatigue, or they'll have, to where they're not able to move very efficiently. So that's the second way that happens. And probably the third and most important way that this presents, because it's exceptionally lethal, is cardiac arrhythmia. So the muscle of the heart is very similar to the muscle in the skeletal system, and it depends on charges to reset the muscle in between contraction. And when you have too much or not enough of something, especially like potassium, if you have too much potassium, those charges get wrecked out. And so you can't reset in between contractions, and you can end up with arrhythmia. And arrhythmia is when the heart starts beating irregularly or not the way it's supposed to. And as you can imagine, when the heart stops working well, that people die. So we do see this clinically quite often, and it becomes very relevant, again, because it's lethal. Now, as an EMT, we don't typically, you won't be correcting these, but they're still worth knowing, okay? So real quickly, people that are at risk of like electrolyte depletions, right? People that have had vomiting and diarrhea for a long time, this list is not exhaustive, okay? So people that have nausea and vomiting, people that have renal failure, so people that have kidney disease, um, people that are malnourished, of course, people that overdose, that becomes an issue. Diabetes can lead to this issue. Those are probably the bigger ones. It's intuitive. People that have lost electrolytes, right? People that have done strenuous exercise, like marathon runners and stuff like that. You ever hear the marathon runner that's running and they just plop over dead? A lot of times that's electrolyte imbalances that led to arrhythmia. So it becomes pretty relevant and important. So that's why I'm discussing it. Now, anyway, sodium. So if you know on the periodic table of elements, sodium is Na. So hypernatremia, right? That means there's too much sodium. And hyponatremia, there's not enough sodium. So that's those words that you might see thrown around every now and then. Okay. Potassium, if you know on the periodic table of elements, potassium is K. So hyperkalemia, okay, not enough or too much potassium in the blood. Emia means in the blood. So that's where these numbers come from. Of all the ones you don't want messed up, I would say this one's the most important. It's very lethal when this gets messed up. You get arrhythmias really quickly. In fact, fun fact, how we kill inmates in the state of Texas to stop their heart is they will give them a very large dose of potassium really quickly, and it overwhelms the sodium-potassium pump in the heart, and their heart stops. So, I mean, that's what I'm trying to point out is, yeah, like your heart is very dependent on potassium being within a narrow threshold, okay? Calcium, so on the, Ca, right? So it's hypocalcemia, hypercalcemia. Again, intuitive. A lot of our calcium is stored in the bones, okay? Now, speaking of calcium, we'll talk about how this works. It's kind of complicated, but we'll jump into it. So, again, calcium's mainly stored in the bones. We get dietary calcium as well, but if your body's like, oh, I need calcium, we get it from the bones. And here's how this happens. So the thyroid actually is constantly sampling your blood, testing the calcium level. And when we have not enough calcium, it activates the parathyroid, which is the glands behind the thyroid. And it says, oh, turn on thyroid, release your parathyroid hormone. And then this hormone will, in a complex way, end up eventually going to these Pac-Man guys called osteoclasts within the bones, and they chew up the bone, and they spit it out. And when they spit up this chewed up bone, which is rich in calcium, that gets released in the blood. And when that gets released in the blood, the thyroid will then sample the blood and say, there's a lot of calcium in the blood. Turn off the parathyroid hormone. We're at the levels we need now. And so that's probably the most robust way that we monitor calcium and build up calcium when it drops. Another way we do this is parathyroid hormone will activate vitamin D in a very complex way. So it tells your guts and your kidneys, hey, I want you to absorb calcium through your urine and through the digestive system. So that's one way that happens. And really kind of the opposite of when you have too much calcium, it just turns off those systems and it'll tell you to eliminate it and not absorb it. So that's kind of a brief overview on that. I would be shocked if you got tested on this, but there's a lot of pathology related to this, but it's usually not emergent pathology. It's more like, chronic stuff. So like rickets, osteomalacia, stuff like that. Now, phosphate. So, adenosine triphosphate. It's very important, okay? It's used in the currency of ATP. So the clinical one that I think would be important for phosphate is something called refeeding syndrome. So basically, if someone is severely malnourished, like anorexia nervosa, like really, really malnourished, You can't just be like, oh, let's go to the Chinese buffet and wreck it, right? You can't, or CC's and wreck it. I love CC's. You can't do that because when you introduce a lot of food in their body, they don't have enough phosphate stores, and so you can end up with like it can be lethal. Basically, what I'm getting at is if someone is severely malnourished for whatever reason, you can't just go eat at a buffet. It could kill them. So you have to slowly refeed them, and it's kind of a weird thing that happens. But anyways, I'm just telling you it happens, and why am I telling you? It's not like we give buffet meals on the back of an ambulance, but it's worth knowing, I guess, because it could show up on an exam, and it's lethal. Okay, so. Magnesium. So, oops, Mg, right? Whoops, on the periodic table of elements. So, magnesium and calcium are BFFs, right? They're really good friends, and they work closely together um, to regulate each other. So, why am I telling you this? Let's just say you have an alcoholic that's like kind of malnourished, and their potassium levels are low. So they end up with these arrhythmias, and like the doctors give them potassium, and they're like, "What the heck? Their potassium's too much up." It's usually because they have magnesium deficiency as well. So typically, most Americans don't have to worry about these things through dietary issues. I'd say alcoholics are at a high risk of electrolyte abnormalities because they tend to eat or drink their calories instead of eat them. So just be aware, magnesium it works closely with potassium. So if you have not enough or too much magnesium, you tend to see muscular issues and then cardiac arrhythmias. That's probably the more important things to know about that. Okay. Now, disturbance of acid-base balance. So we've talked about this earlier. It's the beginning of chapter 7. So we'll kind of review on this one more time, but let's just kind of dive into this, okay? So we know that when cells do cellular respiration, they produce carbon dioxide. And carbon dioxide is absorbed in the plasma and it turns into carbonic acid, okay? So carbonic acid, intuitively, right, is acidic. So when we have a buildup of acid within the blood, the pH is going to drop. So we need to know that the normal pH in the blood is 7.35 to 7.45. Yes, I want you to actually know that. So if someone has too much acid in the blood, it's going to shift this way, right? So it's going to be like, like someone who has acidosis might be 7.2, right? That's extreme case. But that's acidic, right? So we go this way, it's acidic, okay? And so someone with a pH 7.2, they might have too much carbonic acid in their blood. And so what happens is the body can react in several ways. And remember, what's the quickest way we can get rid of acid? What's the one that takes seconds to work? It's the lungs. Remember, we can breathe off CO2 and get rid of CO2 really quickly. The other system that takes hours, I really want you to know it takes days for it to kick in and work efficiently, is the kidneys. And the kidneys can produce this stuff called sodium bicarbonate. And sodium bicarbonate will go into the blood and it'll grab those little hydrogen ions and it'll wrap them up and say, "Not today, sucker." And it won't let them be their little acidic nastiness. So sodium bicarbonate is really good. It's a buffer, right? It buffers the hydrogen within the blood. And where is it produced? It's produced by the kidneys. How long does it take? Days. So where I'm getting at with this is when we have too much carbonic acid in the blood, the quick response is for the body to breathe faster. And I'll give you an example. If I were to tell you, go run to the stop sign and back, right? You're going to come back huffing and puffing. Why is that? Your cells just did a bunch of cellular respiration, probably anaerobic at that. And then it produced a lot of carbon dioxide that was bound in the blood as carbonic acid in the plasma. And then your body said, "I need to get rid of this. So what can I do? I can breathe faster." So when you come back and you're like, "Hey, Hunter, I'm back from the stop sign," you're going to be huffing and puffing and blowing the house down because you're trying to get rid of this CO2. So that's a very real life example of a buildup of CO2. It's if you were to go running. And so your kidneys won't kick on quite yet. So when that happens for a sustained period, the kidneys do kick on and produce sodium bicarbonate. Okay. Now, there's these, and we're going to cover these pathologies specifically in the chapters, but I'll lay a foundation now. Um, so real quick, let's talk about respiratory acidosis. The example I just gave you is respiratory acidosis, right? I tell you to go run. You're not able to breathe off the CO2 as fast as it's being produced. So you're having to really huff and puff to get rid of it. The more common example of this that we'll see in the pre-hospital environment is someone that overdoses on narcotics like heroin or morphine or fentanyl or Dilaudid or something like that, oxycodone. So what happens is when you overdose on those, it suppresses the respiratory system. And so when the respiratory system gets suppressed, instead of breathing our normal 12 to 16 times a minute, you might breathe 2 times a minute. So what happens when we breathe 2 times a minute? You don't breathe off the CO2. When you don't breathe off the CO2, it builds up in the blood. So we end up with acidosis because the carbonic acid is building up. But what is the cause of the acidosis? It's respiratory. So that's respiratory acidosis. That's probably the more relevant way that we'll see respiratory acidosis. We also see this in like asthma and COPD, but like lung disease. But a narcotic overdose is a real classic example of respiratory acidosis. How do we fix this? How do we fix hypoventilation? We ventilate. We just ventilate them. Okay, it's easy. Now, respiratory alkalosis, we don't really see a lot of this, but it's caused by hyperventilation. So the classical vignette is someone that's having a panic attack or anxiety, 21-year-old female hysterically crying after failing out of college, she passes out, right? Respiratory alkalosis. So you can breathe off so much CO2 that instead of the pH being 7.4, where it's supposed to be, it'll go up to 7.6. It's alkalotic. That's basic. That's alkalosis. So you have alkalosis that is caused by a respiratory problem, hyperventilation. So that's respiratory alkalosis. Okay. Now, metabolic acidosis, we see these in a lot of conditions. The most common one, there's a lot, but a common way that this happens is sepsis. We'll talk, or really, I don't want to talk about that. Let's just say shock. Okay. So if someone has shock, whether it's septic shock, which is like a form of distributive shock, or hypovolemic or cardiogenic shock, what happens? What is shock, right? Shock is the lack of perfusion to cells. So what happens when cells are not perfused? They switch to anaerobic meaning without oxygen, metabolism. And so we know that the byproduct of anaerobic metabolism is lactic acid. Hence acid, the word acid, lactic acid. So when we have this lactic acidosis build up in the blood becomes acidic. But it's not acidic because of a breathing problem. It's acidic because of a metabolic problem, right? You're not able to perfuse the cells. So we end up with a condition known as metabolic acidosis. And so the common way that this happens is shock, like septic shock, which is a form of shock because of severe systemic infection. We can see this in diabetic ketoacidosis. Okay, it's for a different reason. You've ever heard of the keto diet? Ketones are acidic. So as ketones build up in the blood to a toxic level, the blood becomes acidic. So that's a common way this happens. So metabolic acidosis, pop quiz. What do you think the pH will be of someone with metabolic acidosis? It's going to be less than 7.35, right? So it could be 7.3, 7.29, something like that, okay? Now, metabolic alkalosis, this doesn't happen very often. You probably will never see this, but this happens from like someone ingesting too much Tums. I know, weird, right? So like too much bicarbonate, right? So if someone were to like take a whole bottle of Tums, they could end up in metabolic alkalosis. So their pH might be 7.6, or something like that. And it's metabolic. It's because they overdosed on something. That's probably the most common way this will happen, okay? But it doesn't happen. Metabolic alkalosis does not happen often. So if these confuse you, they're actually worth knowing. Like, again, we're going to cover these more in subsequent chapters, but they are relevant, right? Like we do treat these and identify these in the pre-hospital environment, and it's very testable information, okay? Now, cellular injury, we're going to jump through each of these at a pretty, broad level, but let's hop into it, right? So just straight up cellular injury, I want to point something out. This is a muscle cell, okay? You can see the striations in it, and you can see that there's like cellular machinery. Like this is, let me use this color. That's a nucleus, okay, of these cells. And so basically, this is a normal cell. And what happens is when we get hypoxia or cellular injury, we tend to see cellular swelling. And so as you can see, this area has been hypoxic. It's been injured, okay? And so we end up seeing swelling of the cells. We don't have this nice striated muscle anymore. It's like very swollen. And we also tend to see like loss of the nucleus because they've been destroyed from necrosis, right? And we see that there's this nuclear debris. Again, the cells have been destroyed. So this is a bad thing. And a general pathology rule that's kind of important to know, because we see this a lot in like stroke and heart attacks, is um, remember me talking about the whole sodium potassium pump thing? Well, what does the sodium potassium pump exclusively depend on? It depends on ATP. And what do we need to make ATP? We need glucose and oxygen. So when we have hypoxia, right, or shock even, when we have shock, for whatever reason, cells can have not enough ATP, which then we don't have enough fuel to run the ATP pump. So when the ATP pump stops running, or the sodium potassium pump stops running, we end up with cellular swelling. And the reason this is water follows salt, water follows salt, water follows salt. So if we have salt staying inside the cell, water will follow. And if it's not being pumped out, the salt's not being pumped out of the cell by the sodium potassium pump, which requires ATP, you will end up with cellular swelling. And the swelling can swell so much, in fact, the cell can lyse, it can split open. And when the cell splits open, it dies. You know, it leaks all its contents out. So this is an important hallmark because we see this in like heart attacks, we see this in strokes, we see this in certain viruses, we see this in a lot of pathology that when cells are uh, hypoperfused for whatever reason, or hypoxic, or suffering from shock, they tend to swell. So it's a hallmark of pathology. Cellular swelling is due to like ischemia or infarction. Okay. Now, hypoxic injury again. Um, certain cells like your brain cells, heart cells, kidneys, very dependent on oxygen and ATP and glucose. So when we don't get that, they're very quick to start dying. And so we see, hypoxia and shock first in these cells, right? Like we see hypoxia in the brain really quickly, really early on, because they're so dependent on oxygen. Okay. So hypoxic means hypo, which means low, and then oxic is referring to oxygen. So low oxygen injury is what this means. Students will sometimes get confused with the word hypoxemia. It's very similar, but what I tell you earlier, what does the word emia mean? It means within the blood. So it's low oxygen within the blood. Okay. Chemical injury. So we can see this with like pesticides, cyanides, carbon monoxide, lead. I'll give you an example. Cyanide and carbon monoxide, they both can eventually shut off the whole electron transport chain thing that produces ATP, So if you turn that off, you die very quickly. We see cyanide from house fires. It's the byproduct of combustion of inorganic materials, right? So like couches, carpet, stuff like that. Pesticides, this is obviously like pesticides. Lead, someone that's hanging around lead paint or like bullets, stuff like that, works in a factory, fireworks, stuff like that. Carbon monoxide, again, it's the byproduct of combustion. Okay, so CO. And then ethanol. What is ethanol? It's alcohol. So alcohol at high doses is very toxic. And interestingly, alcohol is toxic, but also the byproducts of alcohol is toxic. So, alcohol produces a stuff called NAPQI in the liver, and that itself becomes really toxic to the liver. So it not only is alcohol toxic, but the byproduct of alcohol is toxic. And that's actually probably the more lethal part of alcohol intoxication. It's what causes cirrhosis, is the byproduct of alcohol. So anyways, yeah, cells can obviously get damaged or destroyed by chemicals, infectious injury, right? So, different bacteria and fungus and viruses can go into the cell and cause damage. So, like, you ever heard of mono, like the kissing disease, Epstein-Barr virus, right? That can cause a certain type of blood cancer. HIV can cause a lot of different cancers and diseases, right? Certain viruses, right, or bacterial infections can cause injury to cells, like diphtheria or, tetanus. All these, virtually all of them will cause some type of cellular injury. But real quickly, how do viruses work? Viruses go into the cell and they hijack the machinery of the cell, the cellular machinery. So they're almost like these Taliban terrorists that'll go into the cell and hijack the machinery of the cell and convince our normal cells to start producing virus stuff, RNA, DNA, proteins, and that's kind of how they work. Bacteria just tend to straight up invade the tissue, and fungus are similar to bacteria, really. But anyways, what is virulence? Virulence is how, like, well, as they call it, disease causing something is. So, like, tuberculosis is a very virulent something. Okay, very virulent bacteria. HIV, very virulent. But I'm trying to think of something that's on the lower end, like staph epidermidis, right? So it's normally on our skin, not super virulent. Candida, it's a fungus that's probably on your skin right now, not super virulent. So it just kind of depends. It's on a spectrum of these virulence, okay, factors. So a depressed immune system is less capable of fighting off a microorganism. So who has a depressed immune system? So first off, people that are taking immunosuppressants. So someone who has had a transplant, like a liver or kidney transplant, we intentionally suppress their immune system to keep their body from attacking this transplanted object in their body. So those are people at risk of infection. So they're immunosuppressed. People that have AIDS, they're immunosuppressed. People that have autoimmune disorders, right? Autoimmune is when people's own immune system attacks their body. So how do we treat that? We tell their immune system, we're just going to shut you down. We're going to weaken you. So you give them medicine that'll weaken their immune system, so their immune system can't attack its own body as well. So autoimmune disorders are like lupus and myasthenia gravis and multiple sclerosis, and the list goes on and on. But that's an example. So we intentionally will immunosuppress people. People that are taking chemotherapy, they tend to be immunosuppressed because we knock down the rapidly dividing cells in the body, and one of the most rapidly dividing cells in your body is your hair and skin. That's why they lose their hair. But white blood cells are rapidly dividing, so when you shut that off for a body, they can't produce a lot of white blood cells, so they can't fight very well. So, anyways, that's kind of like some general idea of infectious injuries, some basic immunology, pretty high yield. Um, so for whatever reason, they want you to know that some bacteria, not all of them, but some bacteria have a capsule that protects them from phagocytes, right? So remember the phagocytes, right? They're those little Pac-Man guys that'll go in there and start chewing up stuff that they need to chew up on. But if you have this encapsulation, right, like a capsule or film around a bacteria, it makes it a lot harder for the phagocytes to do that. So just something worth knowing, that if things are encapsulated, it's really hard for uh, them to get phagocytized, right? Like to get bitten up on. Okay. Um, so this is just talking about straight up inflammatory response, and I think this next slide kind of does well. But basically, we have this general response to inflammation, right? And it consists of heat, redness, tenderness, swelling, and pain. And I'm going to talk about why all these happen, but we see this, okay? So if someone were to smack your cheek, right, really hard, or if you were to be stung by a bee or burnt, right, we will see in every one of those scenarios inflammatory response. Just happens to be local response, right? So you'll see heat, redness, tenderness, swelling, and pain. And so here's how this happens. You have, let's go with a slap on the cheek, okay? A really tough one, like you really earned it, right? Big slap on the cheek. The first thing that you're going to see is capillary dilation. So remember, capillaries are these little anastomosis, like this joining of arteries and veins, very small, microscopic joining. And so if I were to poke your finger and it just kind of oozes blood, that's capillary blood, okay? It's at the very end of the line, smallest part of the vasculature. And so what happens is there's going to be these inflammatory mediators that are released from cells, and they're going to say, capillaries, you should dilate because we want more cells, more blood to come to this area to help us fight, okay? And so the capillaries will dilate. So you end up with this increased blood flow. And when you get increased blood flow, you see redness, right? And blood is hot, so you feel heat, redness and heat. So that's how that happens. And then we'll also see not just increased capillary dilation, we see capillary permeability. So the stuff in the capillaries now becomes permeable. So it can leak out. By design, God says, let's let these white blood cells and red blood cells leak out of the capillaries so they can go fight in the third space or wherever they need to go fight, at your bone or at your bee sting or the slap on your face. So again, that can contribute to redness and heat as well. But we also have this attraction of leukocytes. So this is when we have migration of white cells to the site of injury, or white blood cells to the site of injury. So leukocytes are just straight up white blood cells. And so we get this white blood cell response to the area. Okay. So leukotrienes, leukocytes, they'll get neutrophils, right? Again, these little Pac-Man white blood cells, they'll go in there and start released to that area. Okay. And in fact, if you've ever wondered what pus is, right? If you've ever seen an abscess with pus, those are just straight up dead white blood cells that have gone and fought their fight. Okay. So white blood cells really are white. That's what pus is. Okay. And then the systemic response. So we'll see the systemic response of fever. Okay. So it goes up to the hypothalamus. Where's the hypothalamus? The diencephalon. And it'll raise the body temperature, which increases it. Some viruses and bacteria don't do well at higher temperatures, so that's why that happens. One of the reasons that happens. And then leukocytosis. So leukocytosis is the increased production of white blood cells. Okay. So all this comes together to produce heat, redness, tenderness, swelling, and pain. And then we have this injurious. So there's genetic factors that can injure cells, right? So if you don't know, as we age, mutations occur, whether it's from the sun or alcohol or just general life, mutations occur. And typically our cellular machinery goes through there and they proof check our DNA as it's replicating and says, mutation occurred, let's get rid of it, let's destroy it. But that doesn't always happen, okay? So we can get genetic abnormalities by mutations, just spontaneous mutations or environmental mutations. We can get this by hereditary, so it's just straight up genetic. It's just going to happen. You were born with this mutation, and you can get it just straight up causes later in life, right? Again, as we age, we get mutations. Okay, and so we can end up with chromosomal disorders, and so we know that chromosomes look like this, right? So chromosome, um, you can end up with an abnormality to where like maybe right here gets this big old clump of DNA that's not supposed to be clumped up. So that can happen. You can get premature. This is weird. It's not genetic, but premature development of atherosclerosis. So this is like plaques in the arteries, and then obesity. Okay, that's really not genetic, so I don't know why it's on the slide, but here we go. Now, injurious nutritional imbalances. So obesity, one of the worst things you can do for your body is be obese. I'm not hating on obese people. I'm just letting you know it's very, very bad. It's because of systemic issues for you, like type 2 diabetes and increased stress on your body. Malnutrition, obviously very bad. Your body needs nutrients to work. And then excess or deficiency in vitamins. So too much of a good thing can be bad, right? So if you're like, vitamin A is supposed to be good for my skin, yeah, it can reach toxic levels. All vitamins can reach toxic levels. Okay, so just be aware of that. Like too much of a good thing can become toxic, and vitamin toxicity is a real thing. And so is deficiency, right? Like 80% of the U.S. population is deficient in some way of vitamin D. So fun fact. So just be aware, like there's vitamin deficiencies even with people that eat a balanced diet. Now, mineral excess or deficiency. So what are minerals? So salt, right? Potassium. If someone has way too much salt at dinner, right? They like if you're just like salt shaker, a bunch of salt, you could end up with arrhythmia or kidney disease or there's a lot of hypertension. There's a lot of issues you can run. So again, too much salt, not enough salt, too much potassium, not enough potassium, you can end up with cellular injury and issues because of this. So heat, cold, and radiation. So probably the more common source of radiation that we'll see in the United States is from the sun. The sun does produce radiation, and so that's an issue that we see occasionally. And then also from heat or cold. So the thing I want to point out is, of course, if you're exposed to like a 900-degree piece of metal, it's going to destroy your skin, right? But I want to point out an example. I have a close friend that recently sat on like a forklift fork and was raised up like 20 feet to go fix a flagpole. And it was hot. It was in August and summer. And as he was sitting on that, he was like, "Oh wow, my butt burns!" Like he was sitting on it, and he can't stand up because he's only on a single fork. And so this fork was probably like 150, 160 degrees because it's been out in the sun and it was black. But since he couldn't get up and he was stuck on it for like 45 seconds, he ended up with like second, almost third degree burns to his butt. And what I'm pointing out is the fact that even at fairly low temperatures, like 140, 150 degrees, for a sustained period of time, that will cause burns, right? Same thing for cold, right? Same thing for heat. Same thing for radiation. The sun. fairly low radiation compared to a nuclear power plant. But if you have sustained exposure to that, it will damage your DNA. So I'm pointing out that, of course, the strength of an exposure becomes really important in the acute setting. But even at a low strength of exposure of heat, cold, or radiation, if you have a long duration of exposure of it, it's still damaging. Okay. Apoptosis, right? So it's programmed cell death. So apoptosis is just programmed cell death. So remember me telling you that the cell, or there's machinery within our cells that will go through there, and they're like almost like policemen, right? And they're like looking at the DNA, da, 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 like, oh no, you're bad. We're gonna go ahead and let you go. We're gonna go ahead and kill you. Okay. So what happens is it says we can be civil about this. We'll recycle as much of you as we can, but your DNA sucks or your cell sucks. So we're just going to go ahead and let you go here. So they end up in a very friendly way killing and destroying the cell to where it'll die. And it's through programmed cell death is how this occurs. And so that's how this happens. And it the proteins in the DNA they'll get degraded, and sometimes it's reused. And this is normal. So cells die, right? Like our body will go through and be like, "You're old. We're gonna let you go. We're gonna go ahead and kill you." But it's a friendly way. So they're real cool about it. So there's not a lot of swelling, is what I'm getting at. It's very programmed. It's very civil. It's like the nicest execution you've ever seen. So this is normal, okay? And we see this, but I would say the more common way that this happens is, again, your body will be scanning out cells and be like, you've lived a good life, but you're kind of getting old and raggedy. We're going to go ahead and let you go, and they execute them in a friendly way, okay? So this is kind of how this looks, right? So whether it's a virus like HIV or the sun or, carcinogens or whatever, when it starts infecting a normal cell and it turns to an abnormal cell, what should happen is the immune system should be surveilling that, and it's like, no, you're done, buddy, and apoptosis should occur. What happens is, or even necrosis can occur. What happens though, if we have that cell that's been exposed to a bunch of radiation from the sun, and we don't kill it, we don't shut it off, we can end up with cancer. So this is how a lot of cancers take place, is because the normal process to check these bad cells doesn't work, so that you end up with a cancer. Okay. So necrosis is tissue death that's not normal. So tissue that has been hypoxic. Remember me showing you that cell earlier, the one with the muscles side by side, the one that looked really bad. That was necrosis. So that was on its way to necrosis, to where there was cellular swelling and the cells had exploded and lost a lot of the nuclear contents outside of the cell. So those cells had exploded and they were swollen. So necrosis, I want you to think, exploded cells. This is after severe injury. It's not friendly. This is straight up execution style. Not a good thing when this happens. So we see necrosis in stroke. We see this in heart attack. But this is different than apoptosis because it's not programmed. It is not friendly. There is cellular swelling in necrosis. So necrosis is a really ugly, messy way for a cell to die. It's usually from cellular injury or insult. Almost always, actually. Okay. What is hypoperfusion? Well, I'm glad you asked. It's shock. So hypoperfusion equals shock. So hypo, low, perfusion. So what's perfusion? Perfusion is the delivery of nutrients to the cells, okay? What's the greatest test of perfusion? It's capillary refill. It's the most underrated thing ever. So I'm going to put my finger right here in front of the camera. See how it's fairly pink? If I were to take my finger and push down on my capillary bed, it blanches white and then it goes right back to pink. So what does that mean? It means that I'm pushing out the blood from the capillary beds, but it's very quickly coming back into that space, okay? The same thing can be done like right here on my hand. I could push down on it. Look, it's going to go white, and it goes back to the normal color because I pushed the blood out of the capillary areas. That's called capillary refill. It should normally be less than 2 seconds, okay? But if someone's in severe shock and you grab their finger and push on it, it may take 5, 6, 7, 8, 9, 10 seconds to go back to normal. And you could do the same on an extremity, and you're like, oh wow, it just stays white after I push down on it. That's hypoperfusion, also known as shock. So the greatest indicator of perfusion is by far capillary refill. And guess what? You don't have to have a fancy machine to assess this. You just use your eyes. Like, it's very, very helpful. I will say there is a caveat. Cold temperature can affect this, obviously, but very, very helpful tool. I use this a lot clinically. So back to shock. What is shock? It's lack of perfusion to the cells. So the cells aren't getting enough oxygen or nutrients, could be in the form of glucose, delivered to the cell. Now, why this happens, there's several reasons, and we're going to cover these. So, and again, we'll have an entire chapter on shock, but this is just general pathophys right now, pathophysiology. So, um, shock can occur due to central or peripheral circulation issues. So if it's central circulation issue, these are typically from cardiogenic or obstructive shock. So let's just jump into these. Uh, so I want to point out, cardiac tamponade is not cardiogenic shock. It's obstructive shock. So this is a form of obstructive shock. Okay, so it's obstructive shock. Even though it has the word cardiac in its name, it's not cardiogenic, it's obstructive. So if someone obstructs you, what are they doing, right? They're inhibiting you from going about and doing what you're supposed to, like physically obstructing you. Okay? And that's what's happening here in cardiac tamponade. This is pronounced tamponade, not tamponade. It's not lemonade, tamponade. So cardiac tamponade. And so the heart, beating thousands of times a day, it has lubricant around the heart in a sac, and this sac that sits around the heart is pericardium. And so it's this fibrous sac that has some fluid inside of it, and then the heart that sits around the heart. But it's fibrous, so it's really like it's not stretchy. It's like leather, thin leather. So what happens is you can have a buildup of blood or fluid in there from like trauma or like infection and stuff, and you can end up with swelling of fluid around the heart. Well, as you can imagine, if you have your heart that's trying to beat, but there's fluid that's building up around it, you might start squishing on the heart. And as you squish on the heart, you won't be able to pump as efficiently. And what happens is you end up with obstruction. And so that is obstructive shock. Okay, this is obstructive shock. So the heart is physically, literally being obstructed from opening up and beating by design. What's obstructing it? Usually it's blood, but it can be fluid. But in EMS, it's almost always going to be blood, is what they're going to tell you. So if someone gets, I don't know, a steering wheel to the chest, they could end up with cardiac tamponade. We'll talk more about this in chest trauma. Another form of obstructive shock, which is a form of central shock, is this thing called aortic dissection. So let's see what this looks like. So let's imagine that your heart's here, okay? And the aorta is this huge vessel that runs off of it. It's the biggest one. And so blood's coming out of here in really high pressure. And there's 3 layers to the artery, right? So there's the tunica intima, which is the inner layer, the tunica media, and the tunica adventitia. So what happens is, for whatever reason, there will be a little tear in the tunica intima right here. And since this is high pressure, blood goes, oh, wow, cool. We can start sliding in between layers, and we'll just start going this way. Well, when this happens, it tears. So it starts like imagine a water hose with layers, but you're tearing in between the 3 layers of the water hose. So it ends up with like this ballooning. So this feels like tearing in your back, by the way, and it can tear so much, this could eventually rupture. And if it ruptures, you're dead. But very quickly, you will die. But this has to be surgically fixed if they can fix it. This is really bad. Well, why am I telling you this? Well, this ballooning, again, can obstruct the heart, and it can cause obstructive shock. So this is a form of obstructive shock. They want you to know that. Another form of obstructive shock is a pulmonary embolism. Now, peripheral shock. We have 2 different ways that this will present. The first one is hypovolemic shock. Okay? So what is hypovolemic shock? Break down the word. Hypo means low, volume, volemic. So it's low volume shock. So think about this. We have low volume shock. So how do we lose volume? The more common way that's going to immediately come to your mind is someone gets shot in the face or something, I don't know, and they start leaking a lot of blood, or their arm gets ripped off, and they're just shooting blood across the room. So someone very obviously losing blood, pooping blood, vomiting blood, hypovolemia, okay? And if you lose so much blood that you're no longer able to perfuse your cells, that's shock, hypovolemic shock. But another way that this happens, it's commonly missed, is vomiting and diarrhea, okay? If you are pooping your guts out for 5 days straight and you're not able to keep fluids down, you very quickly will become hypovolemic. You're still losing volume. So be aware that hypovolemia is not just blood. It can be just straight up volume. Okay. And then distributive shock is the widespread dilation of vessels. Okay. Incapacitants too. So what does this mean? I'll just break it down. You ever heard of anaphylaxis? Okay. So this is a systemic response to an allergen that tells your whole body, hit the big red panic button. Let everyone panic. So what happens is you'll have widespread dilation of all your capillaries and venules. So remember me talking earlier about how we can have local inflammatory response if I slap you on the cheek, right? That's local. But what happens is instead of just being your cheek, your whole body will get red and swollen and tender and pain, right? It's the whole widespread inflammatory response, and your body's not designed to do widespread body-wide inflammatory response, so you can end up with distributive shock. So instead of just having a little swelling to your face, for lack of a better word, you get widespread body swelling, and that's distributive shock. So this becomes a really big issue in like septic shock and anaphylaxis, neurogenic shock even. And I think we're going to talk about these. So yeah, anaphylactic shock. So anaphylactic shock is this pesky thing called histamine. It's released from blood cells, like white blood cells. And what happens is it tells the capillaries to dilate and become permeable. Well, again, in anaphylaxis, instead of that just happening at your bee sting where it should normally occur, your whole body says, dump all the histamine. So you dump all your histamine, so you end up with widespread vasodilation, and so you end up with distributive shock. That's anaphylaxis. Again, instead of the bee sting swelling just on your hand where you were stung, your whole body, for lack of a better word, will swell and dilate. And then septic shock, this is widespread inflammation or infection that results in systemic inflammation. So instead of just fighting your sore throat, for example, or like your urinary tract infection, the body says, big red panic button. We're gonna fight, like the whole body's gonna fight instead of just your throat fighting and getting swelling and signs of inflammation, the whole body. So they present very similar, anaphylaxis and septic shock. They're very similar in pathology. And then neurogenic shock. So, if this is someone's spinal cord and this is their brain, what happens is if you like sever the spinal cord completely, it has to be a complete transection usually, you can end up with neurogenic shock. So what happens is the sympathetic tone within the spinal cord is lost in neurogenic shock because of the transection. So what is the sympathetic nervous system, right? This is the fight or flight. This is like, oh shit, I got to fight a bear. So I need my heart rate to go up. I need my vessels to close down. I need my eyes to dilate. I need my guts to turn off because I need to fight. So what happens is if you lose that, you lose the thing that squeezes down on vessels and increases the heart rate and dilates your eyes. The parasympathetic nervous system will kick in and it causes vasodilation. So you end up with lack of sympathetic tone is what they'll say. And so you end up with, again, if the vessels are like, I don't have sympathetic tone, I no longer need to be squeezing down, they just relax, and then you end up with distributive shock. So that's distributive shock. Again, there's a whole chapter on this. We're going to go over this, but I'm laying some foundation now. Why? Because the book said I should, so we are. So moving forward. This is what I just talked about. Now, many types of shock are characterized by reduced cardiac output. What's the cardiac output formula? Anyone? Right? It's stroke volume times heart rate equals cardiac output. Got to know that one. So how much blood are you stroking out in a single volume? Or how much volume are you pushing out in a single stroke, sorry. And how much, what's the heart rate? That's your cardiac output, okay? So you'll have circulatory insufficiency and a rapid heartbeat. A late finding in shock is hypotension. An early finding in shock is altered mental status, decreased capillary refill, okay? So that's what I was talking about. So you can evaluate the presence of volume and peripheral pulses and assess end organ perfusion and function. So what is the first organ to get wrecked out in shock? Anyone? No? I know I'm talking to myself because I'm in a room by myself, but no, it's the brain. You'll see altered mental status. One of the first things you'll see. Okay. Now we're almost done. This is the last slide, but I want to talk about this thing called multi-organ dysfunction syndrome. It's called MODS, M-O-D-S. And so basically what happens is, let's just say that, trying to think of a good example here. Yeah, we'll just use, we'll use the heart. let's just say someone has cardiogenic shock. What's cardiogenic shock? It's shock that is when the heart is not beating fast enough or efficient enough, or it's beating too fast. Basically, the heart is failing for whatever reason, and so it causes shock. It causes lack of perfusion. The pump's not working well, so the cells are not being perfused. Hypoperfusion means shock. So that's called cardiogenic shock. And so in cardiogenic shock, we can end up with not enough pumping to organs. So we might really quickly see, oh, they have an altered mental status because the brain's not working. We might eventually see, oh, they haven't peed in a day and a half because their kidneys aren't working. And we might see their skin is really pale, and oh, their guts aren't moving anymore. And, whatever organ systems get wrecked out. What I'm saying is MODS, multiple organ dysfunction syndrome, is when one system fails and multiple systems will fail after that because they're dependent on each other. Where you see MODS, which is probably a better example than the heart example I just gave, is in sepsis. So MODS is a really good indicator in sepsis. Remember, sepsis is the type of shock that relates to infection. So if someone gets infection, you might see really quickly, you're going to see multiple organ dysfunction syndrome. They might have altered mental status, and their kidneys won't work, and their heart they might start having chest pain or shortness of breath or whatever. And so we see more than two or more organs or organ systems start to fail when they were initially unharmed, right? So your sore throat shouldn't be jacking up with your brain and your heart and your lungs and your skin and your kidneys. So it's when an unaffected organ gets wrecked out because of the shock. And so this is a good indicator of shock, to where when you see this, it has a pretty poor prognosis, because the next thing is you'll be in full-blown shock, right? Like geez, what's the word? I can't think of the word. Uncompensated shock. Geez, sorry. Uncompensated shock, to where you cannot compensate any further. Geez, that was embarrassing. So anyways, this is the last slide for this one. The next one's going to cover some immunology, and I just want to break it up, try to make this in more bite-sized pieces. So yeah, I appreciate your attention, and we have one more video in this chapter.